We're all aware that there are changes happening in the healthcare field to improve outcomes and lower costs. And these changes affect all of us as clinicians as well as patients. Interprofessional collaborative practice is a key element in patient-centered care. And because ASHA recognizes the critical role that IPE, IPP plays in healthcare, it's a strategic objective in the strategic pathway to excellence. So now a few words about our guest speaker. Dr. Elena Umland is Associate Dean for Academic Affairs and Professional Pharmacy Practice at Jefferson College of Pharmacy at Thomas Jefferson University in Philadelphia, Pennsylvania. In January 2017, she was named co-director of the Jefferson Center for Interprofessional Education. Dr. Umland is a 2007 graduate of the Academic Leadership Fellows Program of the American Association of Colleges of Pharmacy, AACP. And currently, she's chair of AACP Women's Faculty Special Interest Group. Her academic responsibilities include oversight of the Jefferson College of Pharmacy's curriculum and assessment plan. As co-director of Jefferson Center of Interprofessional Education, her focus is on consistent evaluation of all Thomas Jefferson University's IP activities in an effort to count student participation and identify transcript designation for their efforts. Her scholarly activity has focused on interprofessional education via collaboration with pharmacy colleagues around the country, as well as non-pharmacy colleagues within Thomas Jefferson University. It gives me great pleasure to introduce Dr. Elena Umland, and please give her a warm welcome.
So one of the slides that Arlene presented noted, and I wrote it down so I wouldn't forget the details, 64.8% of you will not be employed in private practice. So what does that mean? Where are you going to be employed? I did some research. I know where you all are employed, but you can tell me. Where are you all employed? Where will you be employed? Bulk of you are students. Raise hands. I'm going to ask you questions today. I'm not just going to talk at you for, yes. Hospitals. Where else? Yes. Universities. Where else? Schools. I found that in some of my research that you do go into schools, school districts, right? Okay. So when you go to those places, who do you work with? In the schools, who will you work with? I'm putting you on the spot because you said schools.
Children and their teachers.
Children, their teachers. In the hospitals, who do you work with? Physicians. Anybody else? Who helps to coordinate care in the hospital a lot? I heard it. Nurses? Nursing? I'd imagine any OT folks you think you might interact with, I would suspect. And what was the other place? Well, in the universities, you're going to interact with whoever all you are lucky enough to work with. I will say at Jefferson, I have colleagues in PT, OT, couples and family therapy, nursing, medicine, population and public health, radiologic sciences, the laboratory sciences, and the things that we are doing for interprofessional education. Is this really loud or is it just loud to me? I feel like I'm hearing me talk twice. When we get all these folks together, the different activities that we do change depending upon who's at the table. Oh, thank you. But now I don't know if is that working? Okay. But a lot of what we do, it depends on where folks are in their curriculum, what they're doing, what the focus is, lots of different activities. I'm going to talk about some of those activities today. I will say that from the standpoint of my role in the College of Pharmacy, we're a fairly new school college at Thomas Jefferson University. We entered our first class in 2008. I started there as Associate Dean in 2007, which for me was a switch and a real weird change for a year. I had no students to work with. For the 10, 15 years before that, I was elsewhere and was on this academic calendar of, September to May of students being there all the time. But in that time, we were developing the new program. A huge part of what we did early on was we did at that time have a core group of faculty in medicine and nursing, PT and OT in particular, who were working on moving interprofessional education forward at Jefferson. And they said, we want pharmacy to be a part of that. Well, we want to be a part of that. It was exciting. And I'll say from a personal experience, and I think if I went around the room, I bet all of you could give me one example personally, something that worked well for you in the healthcare system and something that may not have worked well for you or a family member in the healthcare system. When I was in pharmacy school many, many, many years ago, in one of my last years in the summer, my father ended up with a spinal cord injury, very sudden, and any of you who know anybody who's had one, they are sudden. You don't expect them. You don't know what's going to happen. And it changed the family's life for the whole entire future, if you will. And at that time, he spent 8 months at Hershey Medical Center, post-surgeries, post-rehab. And I will say from the standpoint of a family, because what we're talking about when we do interprofessional education or interprofessional practice, the family and the patient is at the center. We're all just kind of around the outside. Because it doesn't matter what we do, we may come up with the best clinical therapeutic plan for that patient, but if that patient isn't part of the plan, and we don't take into account what that patient, their environment, their support system, and all the other things look like, it doesn't matter what we do. But that particular experience, I don't know, it was probably within the second or third week that he was there. They called a family meeting. And at that family meeting, there was nursing, there was PT, there was OT, there was his neurosurgeon. And they kind of laid things out for us. This is what things are going to look like. This is what your dad's life is going to look like moving forward. But we're here to help you. What are you worried about? How can we work with you? We would have never gotten through that had it not been for that team. And I will say, my dad, as the years progressed, was invited to the wedding of his occupational therapist. He became very good friends with his team, as did our family. And, that was a team that worked. And it's not uncommon. Rehab medicine is an area where there are lots of very high-functioning teams. And we talk about interprofessional education and interprofessional practice, where you all are going to go. We're talking about high-functioning teams. We all learn individually, and you bring your special niche to the table. But how do we put all those pieces together? So kind of the history of IPE, we'll talk about that today. Talk a little bit about the development. Deb wanted me to talk about our program at Jefferson, so I will walk you through some of the things that we're doing there. And then when I'm done with my portion, there'll be some time for question and answers, but we have a case study for you all to work on. So I will be breaking you up a little bit to mix things up at the end here today. This is where we were, silos. So you all learn audiology, I learn pharmacy, someone else, they learn PT, they learn medicine, and from the standpoint of pharmacy, when I was trained, I did not interact with someone from another profession until I got to the end of my training and was doing a clinical rotation. And it depended on where the clinical rotation was, who I interacted with, or really if I interacted at all. There might have been other folks there, but my level of interaction, it kind of depended on the place, the people. But what we're trying to do is get rid of these silos. And it was alluded to earlier, and I will talk about why it's so important. Interprofessional education and collaborative practice is not new. It's not new. It's been around for decades. A lot of the original, very early research came out of the United Kingdom. Canada has some really good pieces in place. Their healthcare system, the way it's set up from a collaborative standpoint. But there are some things that really pushed us forward and said, this is, we need to be doing this. And sometimes, I don't know, in the United States, we need a little kick in the pants. And that's what some of this was. So there were these Institute of Medicine reports, and you see this first one goes back to 1999. So to err is human, and this looked at medical errors and how many medical errors we saw a year and the deaths that were a result of them. And at that time, nearly 100,000 deaths annually due to medical errors. Why do medical errors happen? Why do they happen? Yes. Lack of communication is probably the foundational piece. Lack of communication. And why is there a lack of communication? We're getting better now, but some folks who may have been around even like, why do you think there was a lack of communication? Yes.
Because we often have silos in terms of what we do. We focus on our own specialty without communicating with others.
Right. We focus on our own. We don't really pay attention to others. If we do pay attention to others, where does the lack of communication come into play? And this is something we're trying to instill in all healthcare professionals now. What about speaking up? When you think of a team, yes?
One sec, I'm
Oh,
going to give you my...
I guess they're trying to capture everything.
We don't know what the other professionals are doing, like how like in what area they are important for the patient that I am seeing, like what they can do for this patient, like
Okay.
that information is lacking.
So the information from the other professionals and how they contribute is lacking. The medical error piece. One of the things that we saw and we still see is ability and willingness to, and I'll just use the terms, even we use these terms in some of the team steps training, which is now called team safe training, is ability to speak up. So if you see something that's wrong, depending on, I think there was a time, I think, like I said, we're getting better, we're not quite there, but if we saw something that was wrong, depending on perhaps the profession where the potential error was seen, we'd be willing to step up and say, I'm not comfortable with that because. So part of this medical error piece is, again, back to the team training. A highly functioning team is not afraid to talk to each other and let each other know that I'm not comfortable with that because. And the because is at the end of that line, at the center of that circle, is the patient. So there's the deaths due to medical errors. So, okay, there's our first piece. And then a couple years later, crossing the quality chasm, which identified deficiencies in the quality of health care and how many Americans at that time were without insurance. And looking at this piece, all health professionals should be educated to deliver patient-centered care. So this is 2001. As members of an interdisciplinary team emphasizing evidence-based practice, quality improvement approaches in informatics. So this came out, big publication, Institute of Medicine. Did we really jump on it right away? No. 2003, 2 years later, Bridge to Quality. Once in practice, health professionals are asked to work in interdisciplinary teams, but we're not educated together. So identifying this is what we're asking them to do in practice, but we're not training them. And then a little further, a few years later, 2010, both in 2010, nursing stated that nurses should be full partners with other healthcare professionals in redesigning healthcare. Full partners. Nursing came out and said that. We should all come out and say that. Pharmacy, ASHA, everybody should come out. We're full partners, because that patient is at the center. And the framework for action, defining interprofessional education and collaborative practice, and we will talk about that, noting the relationship between two. Interprofessional means 2 or more disciplines. You don't necessarily have to have 8, because it depends on the patient. It depends on the situation. You might only need 2 disciplines, but you still need to be able, as the 2, to function well as a team. And then 2013, Interprofessional Education for Collaboration, learning how to improve health across the continuum of education to practice and then transforming care. Aligning interprofessional education with clinical practice redesign. So this was Macy Foundation a couple years ago, and I was speaking with a couple of the faculty this morning. We train you all, this push right now is to train students in interprofessional education. But we also have a responsibility within our organizations to train our practitioners and to make sure that where you are going to do your, whatever you may call them, we have clinical rotations, there's internships, externships. You know, when you go to do that training, are you seeing interprofessional practice practiced? Are you seeing collaboration practiced? Because as students, it's that modeling that you need to see. So from an educational standpoint, and one of the things that we're working on at Jefferson is bringing the whole entire kind of system up to speed. So not just focusing on the students, but focusing on the hospital side of things as well. Measuring the impact of interprofessional education on collaborative practice, looking at patient safety, provider satisfaction. I'm going to talk a little bit about the quadruple aim, and we all come into play there, and assessing progress on the Institute of Medicine report, The Future of Nursing. Nursing is very vocal, and they can always have been, and I'm sure will continue to be, and I think a lot of us could probably learn, when I say us, I mean our other disciplines, could learn a lot from nursing and how vocal they are. So it's not new. This is not new. So, why in 2017 are we now talking about this? So when we talk about the definitions of interprofessional education, when students from 2 or more professions, the pieces I want you to focus on here, about, from, and with each other to enable effective collaboration and improve health outcomes. About, from, and with. If those 3 pieces aren't there, I would challenge that it's not really interprofessional education. If we stick you in a classroom with medical students and you're learning about something, but you're not learning about the medical students, you're not learning from the medical students, you're not learning with them, they aren't learning with you and about you, it's not interprofessional education. It's merely putting a bunch of you in a classroom together. So that about, from, and with, those 3 key elements need to be there. When I asked you the settings that you go to work in, and you said schools, and you interact with the teachers, and you interact with the students, you need to know about those teachers. What is it about those teachers and what they do with their students you need to know in order for you and the teacher and the student to have a plan that will work. When you're in the hospital, depending on what you do, the same type of thing. So about, from, and with. And then collaborative practice, very similar when the multiple healthcare workers from different backgrounds work together with patients, families, caregivers, and communities to deliver the highest quality of care. The interprofessional piece, it's not just because we need to do, it's the right thing to do. I will say it's the fun thing to do, too. It's always like, what's in it for me? I think when you work with other colleagues and you're learning from other colleagues, I had mentioned to Deb when I started at the College of Pharmacy and when things started to get really hairy and we had our first group of students coming in and the dean said, is there anything you want me to take off your plate? Do you want me to give the IPE piece to somebody else? No, don't you dare. Don't you dare. I feel very strongly about this. I think when you see a really high functioning team, they're a happy team. They're a happy team. And I could go off on, the whole happiness thing. You don't get to the next step and become happy. If you're truly happy, inherently, everything around you is good. And if you have a really good functioning team, it's a happy team. I don't think you're going to find an unhappy team that functions well. Happy team function well. So then looking at the health and education systems and kind of where we are, local health needs, improved health outcomes, it's a continuum. What is it that we hope to achieve across this continuum? Fragmented healthcare system, we know where we are with that. And where does interprofessional education and collaborative practice come into play? That interprofessional education piece, the more you learn about other professions while you're in school, the more quickly you are going to jump into practice and fly when you get out of school. Which is part of what we're trying to do here. I had mentioned earlier also to the faculty that, a lot of practitioners, other faculty members, people that I'll talk to, well, we've always been doing that. I don't know if we've really always been doing that. We've not, some teams do work very well together, but if you think about how long it took for that team to become a highly functioning team, We want to make sure as you walk out the door that you're practice ready, that you're ready to function in a team when you walk out the door, so that we don't have that lag time. We don't have that lag time of 3, 4, 5, however many years it is for you to kind of settle into being able to function as, a really good member of a team. So that education, making sure that you're collaborative practice ready, and that's where a lot of the accreditation guidelines are looking. What are you doing to prepare your students to be collaborative practice ready, to be able to jump into a highly functioning team? And then when we are able to do that, we're talking about optimizing health services, strengthening the health system, and overall improving health outcomes. But all of these pieces, it's a continuum. So a little bit about our center. We were founded in 2007 with the mission to promote excellence in healthcare through interprofessional education and scholarship, dedicated to implementing and evaluating IPE and collaborative practice throughout the Thomas Jefferson University curriculum. And that's how we started. But as I already mentioned, we really are expanding to the hospital side of things, where we have folks from the hospital coming to us and saying, we need some team training. We need team training. We want to work better as a team. We think we have a good team, but we want to work better as a team. So we've been working on the university side of things as well. And really, this piece of setting standards for patient-centered care and team-based training. I mentioned with some of the faculty this morning when we started. So the center's been around since 2007. One of our first programs, and it's still an existing interprofessional program. It's a longitudinal program in the first couple of years. Some of the students, they hated it. They hated it. Why do we have to do this? This is dumb. This is something it's just extra work to do. I could be studying for this exam or that exam. Why do I have to do this? And I will say that we talked about it this morning, it's being a continuum. We've gotten to the point, it took a lot of patience, it took a lot of faculty who were very dedicated to this for the past 10 years, but we're at the point now where students choose to come to Jefferson because of interprofessional education. We still have the program running. They know that it's an expectation. If they're coming to Jefferson, they're going to participate in this longitudinal IPE program throughout their first 2 years. It's not a matter if they want to or not. But it's been a continuum, and it's part of the culture. And that's why I say where you go to practice, students, that might be something that you look at when you're looking at future employers. What's the culture like? Where you're going to work? Is it a collaborative culture? Is it not a collaborative culture? Thinking about that. But the students, we really have seen a shift. But it's, like I said, it took a lot of patience, and it's taken over 10 years. But within the center, and the other piece for faculty, because I think they probably have questions, how do you do all this? We do have a very dedicated group of faculty, and it is, at this point, a lot of our, Deb mentioned, we're looking at transcript designation. So all of our programs on campus require IPE. How much is required and what is required is a little different, because all the programs don't apply to all of the disciplines. But looking at what does everybody require, every program has at least 2 or 3, I would call them IPE champions from faculty who participate in the creation of the educational endeavors, because you want them to be realistic. You want them to be things that the students can really relate to. So we do have the faculty who work together, and I will say that's one of my great joys, is the things that I've learned from and with my colleagues from all those other disciplines I mentioned up front. But we have a group of faculty within our center. We have 4 different either program coordinators or administrative assistants. The number of students that we have who participate in that required program, each year the cohort is over 600 students in a cohort when you put together all the disciplines. So we really do rely on that support that we have within the center. And the center was initially started, and that first program was initially started by a Josiah Macy grant. So we started with a grant, and then we're able to show the university the impact of the program and the benefits of the program. And of course, having things in accreditation guidelines help to, make people get on board too, so that the university supports the center now. So it's been a long time in coming, and it's continuing to grow. this document, which is one of the documents that you have access to in the information, I think it's on your thumb drive, I believe, the IPEC core competencies. These drive the educational programs that we deliver at Jefferson and whatever IPE programs you may or will be participating in, whether you know it or not. These competencies underline and create the foundation for whatever that activity is. I brought the list because I'm not going to remember. I don't even know how many at this point. So when the first set of competencies were released in 2011, the core competencies focused on communication, roles and responsibilities, teamwork, and then values and ethics. There was an accreditation group of bodies that worked together within these competencies, looking at putting them together, that they make sense, that they apply across the disciplines. I will say ASHA is one of the supporting organizations for this document. I don't know if I counted here how many different organizations, just to give you an idea. Physical therapy, podiatric medicine, the Psychological Association, optometry, allied health professions, social work education, physician assistant, Society of Simulation in Healthcare. A lot of the educational programs actually that we do at Jefferson, interprofessional-wise, are grounded in simulation. So simulation is a part of this organization as well. Podiatric medicine, pharmacy, osteopathic medicine, as well as LCME, nursing. So people are on board. I mean, if you look across the landscape of health professions, everyone's on board with this. When we look at teamwork, roles and responsibilities within these, and I mentioned that definition, learning about, from, and with. That about is the roles and responsibilities. Do you know the scope of practice of an occupational therapist, a physical therapist? That was one of early on the ahas in our program. PT and OT would get so frustrated on the hospital side of things that physicians would just say, oh, we need to consult therapy. They really didn't know the difference between PT and OT. And as a practitioner, you have your job and you want people to know what you do. You don't want to be lumped in with everybody else. And neither do PT or OT. But that was one of the pieces, after a year or two into this, they were so excited, like, finally, people know that we do different things. And on the hospital side and on the provider side, knowing when do I ask for PT versus when do I ask for OT? And not just saying, oh, let's consult therapy. What does that mean? So then the IPEC was updated in 2016 with interprofessional collaboration becoming a specific element within the document. So initially it looked at these 4 areas, but 2016, it was that interprofessional collaboration that was added. I am not going to read these to you. These are in the slides, but what this shows you is several of the health professions and what is included in their accreditation requirements related to IPE. As an educator, you don't want to say that accreditation, completely drives you and makes you do what you do, but you do have to listen to what your accreditation agency has to say, and there's usually reasons for it. I was actually very excited when pharmacy started, adding IPE to the accreditation standards, and when the other disciplines started adding it to the accreditation standards, because that meant everybody had to get on the bus together. We had to do it together. So this is just a couples and family therapy, medicine, nursing, OT, pharmacy, PT, physician assistant, and yes, I did look into your accreditation standards. And while it doesn't specifically say interprofessional education or interprofessional practice, I underlined and italicized, interact effectively with patients, families, other appropriate individuals, and professionals. Are you able to do that if you don't know the roles and responsibilities of those other folks? Are you able to do that if you don't function well as a team or are not a good member of a team? If you can't communicate? If you don't at least share some of the same values that those other folks do? So while it doesn't say IPE, this is IPE. This is collaborative practice. So they are in your accreditation standards. So be excited about that. Be excited about that. The update for the competencies, I said we did add that collaborative practice piece. The things that are bolded and underlined here are the new wording that's put in there. Within the new competencies, there's been more of a focus on population health, so you'll see some of that. Health promotion is a piece that's in there as well. Earlier, someone in the introduction talked about, questions to ask as far as, I believe it was the volume and knowing, from a health promotion and wellness standpoint, you have a lot of things to teach us meaning all the rest of us health providers. You really do. Working together as a team. Are some of the things that you do things that then, if you weren't physically there and part of the team, that as you taught other providers, they might be able to at least think about and do? And would that, in the end, improve overall patient health and outcomes? It would. Part of it's getting out of the silo and feeling that I'm the only one who's able to do this. When we're able to function as a team, we teach each other things, and sometimes other people can take over and do some of the things, but know when they need to actually call us, or know when they actually need to call someone else in and say, I need more help here. So this quadruple aim, and I did make reference to this. Why do we do this? Has anyone heard of this before? The triple aim, the quadruple aim? Yes, I see some hands going up. Big picture, why do we do this? Improving patient outcomes. There's a lot of data out there about teams and how you have better patient satisfaction and you have better outcomes. We need more of that data. But interprofessional team training, increasing patient safety and healthcare quality. Increased patient satisfaction and decreased costs. So the triple aim where we started was the outcomes, the satisfaction, and the decreased cost, kind of rolling them together. When it became the quadruple aim, it was this fourth element, increasing provider satisfaction, acknowledging the role of the workforce, restoring joy and meaning to practice. I will say when you go back, some of the roots of this are in physician burnout, and they make reference to physician burnout and how that has impacted this. But I think what that also speaks to is what I was just mentioning a moment ago, that not one person has to do everything, and knowing when to rely on the other members of the team to get things done and to get things done well, it will increase that satisfaction, it will reduce that burnout. So looking at these pieces, and if we talk about the team and the role of the team, it can do this. We've shown that when we work together as a team, we can reduce errors. We've seen that. We need to get everybody working as a team to reduce errors, not just a few teams that work well. We need to make all teams work well. So where we're heading. So this pit crew on the left side. What do y'all know about a Formula One pit crew? I'm not a racing fan, but it's a really good analogy. Did you ever, I have because I have relatives who are into this stuff. How quickly do these people work? Do you ever watch them? Seconds. And they get it all right. How is that? So they're efficient. We're talking about safety. We're talking about accuracy. How is that? Yes?
Everyone has a specific role and a piece to play that's really important.
Everyone has a specific role and a piece to play that's important, and they know what everybody's role is. So I don't need to do what you do because you're doing what you're doing, and I'm doing what I'm doing. But when we do them together, we get it done right and we get it done quickly. Same way with the healthcare team. The more you know about each other and everybody's roles, how much more efficient, even if you think about it, some of you might have experienced this. If you know somebody who goes into the hospital, they have this problem, and it takes them a few days to figure out they should call this person and they should have called that person. And if you really take a step back, by the time the person's finally discharged from the hospital, if people were on the same page from the time that person went into the hospital, they wouldn't have been in there as long. They wouldn't have been in there as long. but knowing who to call, when to call, and then communicating. Communicating to come up with a plan of which the patient's part of the plan. Barriers. I'm not going to say everything's roses and sunshine and rainbows with all this stuff because it's difficult to do. I mentioned all the disciplines we have at Jefferson, and when I do a lot of the talks that I do on IPE is kind of in the pharmacy arena, but I have a lot of colleagues at other schools who are like, oh, you're so lucky. You have all these disciplines, within your university. I'm like, oh, the grass isn't always greener. Because there are folks who need to reach out to neighboring institutions or neighboring programs to try to make things work. So both ways, there are barriers. Negative perceptions about the utility of IPE, although I do think that that's something that I see declining definitely over time. The perception of add-on or extra work, some people still view it that way, but I think the bulk see the value of it. Our students, when they come to programs, they might come in the first kind of like, but then when it's over, like, I'm so glad I came. That was such a great use of 2 hours, 3 hours, whatever the program happens to be. The organizational structures, this is difficult. Scheduling, space logistics, a lot of the programming that we do, when you talk about team building, when they do an activity, following the activity, we debrief with them, what worked well, what didn't work well, and it's easier to do, and it's better to do, and it's been educationally proven better to do in smaller groups. So if you're trying to find space for all of this, it sometimes becomes a bit challenging, but we've made it work. And then representation across the professions. And then at Jefferson, again, this is something that I definitely see having declined tremendously over the years, but that kind of the turf war piece, this is what I do. Leave me alone. This is what you do. Just go do what you do. Like leaving that at the table. The faculty, when we work together on IPE, early on, one of the, I'll call it rules of play that we put into place for ourselves is you leave the egos at the door. We're coming into the room to talk about developing a program for the students that's patient-centered, that develops team skills, and we all need to leave our egos at the door and figure out what will work best. And that has served us very well. Team of experts does not make an expert team. Enough said, right? You can have the brightest people, but if they don't work together, it really doesn't matter. So some of the things that we're doing at Jefferson, just to give you some ideas. So I talked about that initial program, and I'll call it our kind of core IPE, our Health Mentors program. So our students come in their first year, and they work in groups of, given the size of the programs, most of the groups include 2 to 3 medical students, either a PT or an OT student, a nursing student, pharmacy student. We have our couples and family therapy program, which I love those students being part of the program, but they're a very small program. We have about 20 students, so 20 teams will have a couples and family therapy student. This year, we added the PA program, which is another new program at Jefferson, but they added this. And then there's a mentor. The mentor is a community, we call them a community health volunteer. So the criteria is that they're over the age of 18 and they have one chronic illness, at least one chronic illness. And the students work with this mentor over a period of almost 2 years. They meet with the mentor, first time is on campus, and they do kind of a holistic kind of health and wellness history. They actually do a home visit and go to the home of the mentor. And in that, part of it is looking at determinants of health and the environment. They do an environmental scan when they go to the mentor's home, not just the home, but where they live and what the resources are in the neighborhood where they live. And then within the home, they actually focus on patient safety. So with that team together, with either PT or OT, a lot of it is the physical surroundings of the home and what's safe and what isn't. They work with the mentor to come up with a wellness plan, with the center at the mentor at the center of that wellness plan, because they might have ideas after they do that initial health history, and they're always very excited, their first year in the door. Oh, my mentor has A, B, C, and D, so they probably should be doing A, B, C, and D. Well, if the mentor doesn't want to do A, B, C, and D, you got to go with E if that's what the mentor wants to do, and they learn that very quickly. Part of this program is getting them to see the mentor as a person and a member of the team, not just somebody who has a listing of disabilities and conditions. So all of our students participate in that. And then one of the things that we're doing is we build the curriculum. So we have the mentor up front, and then these knowledgeable, we use the Miller's pyramid of clinical competence, going from knowledge and then competency and then proficiency. Some of these, we call them core interprofessional programs. Team Steps, has anyone heard of Team Steps in here? It's not called Team Safe. It's actually based upon the airline industry, and it is basically team training, teaching folks how to function as a member of a team, teaching them to speak up if things don't seem to be really correct, teaching them to feel comfortable speaking up, teaching them to realize that the leader of the team may change depending on what the scenario and what the problem is. The physician is not always the leader of the team. There could be times when PT is the leader of the team, or where the audiologist might be the leader of the team, because that's the problem that's pushing things forward. So recognizing that team and that role of leader can change. So the team steps, and then we give them scenarios using simulated patients or mannequins, and the students just love it. They don't know what the scenarios are coming in. These are typically second and third year students, so they have a little more clinical information under their belts, and they don't know what's coming at them. And then at the end, what they do is they debrief. It could be a code. It could be some of the earlier Team Steps programs. We have like a mock emergency in a mall, and you have someone who's going into an acute asthma status asthmaticus. We have someone who, their blood sugar drops to the floor, and the students have to they have to figure out what's going on, and as a team, remedy whatever's going on. But then they get to debrief what worked well, what didn't work well, and it might be, you never spoke up. Why didn't you say anything? Or you wouldn't let anybody talk, So there is that kind of discussion and the feedback that they get, and they, they're again leaving things at the door. The purpose is to learn and become a better team member. Discharge scenario, we have students come in, and it's a patient, standardized patient again, who's being discharged after having a hip fracture, who the patient wants to go home. The caregiver is not ready for the patient to go home. They think the patient should really go to a step-down subacute care unit for a while. And this group of students has to figure out how do we lead this discharge team meeting? And they get feedback from the standardized patient on how well they did, whether they really listened to the patient, really listened to the caregiver. And that feedback is the students just love it, because they don't always think about things. And this is the time to, I tell the students, this is the time to practice and screw up, if you will. Do it now and learn from it. And then the proficiency piece at the end, these actually are patient-centered activities that towards the end of the curriculum the students are doing. Where No One Dies Alone is something, it's actually affiliated with a national organization, but there are patients in our hospital system who do not have caregivers, who do not have anybody, who they come into the hospital and essentially it's their last days of life. So we have interprofessional student teams who sit with those patients through their time. And afterwards, those part of it is, it really doesn't matter the disciplines for some of these things. But what they learn about each other, what they learn about the situation. Hot spotting is something else. We're actually collaborating with the hospital, where we're getting a list of our high utilizer patients, the patients who come in and out of the emergency department like 50, 60 times a year or more, and putting together interprofessional groups of students to work with these patients and to find out what resources might they need to impact them in a positive way, so that they're not always using the emergency department. Could be education, it could be getting them in contact with social services. So a lot of these different things. And then the near-miss root cause analysis, and that's part of the team training as well, is getting away from blaming. When something goes wrong, Not blaming, oh, medicine screwed that up. Well, did medicine screw that up? Or did I not speak up? So one of the things some of the students are participating in, and they really like it, we have a physician who's kind of keeping track of near-miss issues that occur in the hospital. And the students in interprofessional teams evaluate these near-miss events to say, what happened? What happened? Who all was on the team? Were there people who should have been on the team but were not? Did people not speak up? Did we not follow policy so that they're learning? And again, looking at process and not people. So there's all these pieces. It's exciting. Can you tell I really like this stuff? I do really like this stuff. Students. I will say the students, early on at Jefferson, we were using some scales that looked at students' attitudes towards interprofessional education and their readiness for interprofessional education, and they were all high. We like it, we're ready. And we've gotten past that, because now we want to see, okay, they're ready and the attitudes are high. What are they actually learning? That Health Mentors program, we actually started collecting some data, and we were so excited to be able to share it with the students. They really were having a positive impact on those mentors. We had mentors who came back to us who had lost weight, who had put shower and grab bars in their tubs, things that we don't always think about as being a big deal, but really could have been a huge deal. So the students really were having an impact. And I think getting that information back to them, like, wow, we really are, we're doing something here. First time with the program, awesome experience. This was actually from a health mentor. My students were very attentive and listened to me, which was the point, making sure they're listening to the mentor. I felt comfortable sharing with them the ups and downs of my life, things doctors don't normally ask but should. One of the students' team steps participants, good to realize the university as a whole values teamwork. So this team steps training is the training that we are working on some of the units within the hospital. Health mentor program participant, from a student perspective, how to look at the whole person, try to learn from their story before you can come up with the best fit. So really learning to listen to everything. And I'm not going to read through these, but it has taken 10 years to be where we are today. And we're continuing to move forward. One of the things that we are doing right now, we have a validated tool. We're probably partnering with the National Center in Minnesota. We have a teamwork observation guide that it's based on the core competencies, but it's been developed that a patient can fill it out, observing the team that took care of them. We use it in the programs for the students to evaluate their peers and the team. So it doesn't really evaluate each peer individually, but as a team. We felt that I feel that our team functioned in this way or that way. And then what we can find, and we do as coordinators of these programs, if there are teams where across the board the students said that this team didn't work, we call them in and we talk to them. Why didn't a team work? Why didn't it work? Because this is the time to learn. And I tell our pharmacy students, because some of the teams are fabulous and some of the teams not so much. You aren't always going to be placed on a team where everything is wonderful, but how do you still function really well within that team? Best case is yes, everybody loves each other and it's a very, very happy team and things are great. It's not always that way, but you could still be highly functioning. Keep the patient at the center. And this is just our contact information. I think these were some resources and the references. And do you all have any questions for me before we... Is there something?
I want you to just wait.
Oh,
Can you hear?
is there something
If you have a question, be sure to wait for the mic.
Oh, okay. Questions? Anybody? Yes.
I have two, but I'll do one at a time. And
Thank
wait.
you.
First, I apologize if I've missed this. The curriculum, and I don't know if you said it, and sorry, I was trying to amalgamate everything. How does it flow in terms of within the program, in terms of either courses or credit relative to their other needs in the program? How does that work over time?
Good question. So the question was how the IPE curriculum kind of fits into our individual curricula, if you will. So I'll use pharmacy as an example. So that Health Mentors program, we have a course sequence that runs throughout, conveniently, our first 2 years. And it's sort of like it's not a practicum, it's a course where we expose the students to things such as emotional intelligence, cultural competency, ethics. It's sort of like a catch-all series of courses where those elements are threaded through the first 4 semesters. That Health Mentors program is part of those courses. So when they do the modules within the Health Mentors program, like that first module is a comprehensive health history, and they do that as a group. They get a grade for that. That's part of their grade for that particular course. Within the Health Mentors program, at the end of the first year and the end of the second year, they're required to write a reflection paper using the what, so what, now what kind of context. And I grade those, and that becomes part of their course grade for that sequence. Team steps. All of our students in the fall of their third year, we're a 4-year program, participate in team steps. That's part of another course that we have on campus. So what we've identified are, we haven't changed the goals and objectives of the courses, but a lot of the activities, if we look at them, help to meet goals and objectives of existing courses, plus meet the IPE side of things. So we look at the courses that exist and say, this might fit really well here. Now, obviously, those of you who are educators know if you put something in, something has to go out because you just don't want to just keep piling it on. So we do have to reevaluate and see what comes out. But the pieces that are required are all parts of required courses for us. The transcript designation that we're working on, we have a lot of students who they want more of this stuff. They really do. And a lot of the other, like the hot spotting that I talked about, the hot spotting piece, they volunteer for, if you will. So with the transcript piece, what we're looking at is, okay, they've completed all these pieces in the pharmacy curriculum that they're required to complete. If they do X number of activities on top of that, they may get that extra certification. And in general, our other programs on campus have done the same thing. They found courses where these activities fit. So it's not viewed as an add-on. It's viewed as a piece of the curriculum. Other questions?
Hello. I have a question about comments from graduates of this program.
Yes.
And how they've been able to incorporate a lot of these techniques and skills into what we call real world settings, because, it's busier in the real world, and these are very, it sounds like very ideal situations that are great for learning purposes, but what about when you have a 10-minute case history and maybe a member of your team is sick, like things like that? Like, how do you?
Can't speak to that specific, but I can give you some couple of things. The Health Mentors program, we've had students that after they graduate, they come back and tell us they still contact the pharmacist that was on their team, or they still contact the PT that was on there. So they've made connections as students that now they come back to those folks. We have had students who have gone on and have basically come back and told us they've been hired and they've obtained residencies and they've obtained certain positions because of the training they've had here, or they've attributed some of the interprofessional training to where they've been able to get. We had a pharmacy student last year who really wanted to get into the Indian Health Service. Normally, in the Indian Health Service, you need to go through several layers to get there, and he had another job, but that was really where he wanted to get, but figured, I'll throw my hat in. And he came back to me, he said, they hired me because of the interprofessional education, the cultural competency that we have, and the emotional intelligence pieces that we have in our curriculum. So if they're trained well, back to your initial question, they know how to deal with that. You know what I mean? So we have, anecdotally, our graduates, and it's across the discipline. I'm not just speaking for pharmacy, but medicine. They've come back like, this is a good thing. I'm getting a stop sign. So the case was a 60-year-old male married with 2 adult children. He has diabetes, high blood pressure, high cholesterol, obesity, and AFib. Recent complaints of sleep disorder, anxiety, and joint pain with several prescribed daily medications as well as several over-the-counter medications that he takes daily. He has been, the reason for an audiologic consult or concerns is fear of losing his job. Boss called him on the carpet several times because he's missing important information at meetings and making mistakes at work. He doesn't want to lose his job. He knows he has hearing loss but has been in denial for several years and decided to have his hearing tested in hopes of keeping his job. The audiology history is noise exposure in the past, military 30 years ago, many rock concerts in his youth. Tinnitus during work meetings. He has been misunderstanding words, cannot understand speech and background noise at gatherings with family and friends, starting to withdraw from social gatherings as a result. Patient and family are frustrated. Wife complains TV volume is too loud. Kids complain their dad doesn't hear well. Patient has been ignoring the complaints. In the observation, the audiologist noticed unsteady gait and asked if the patient was having discomfort in his feet. He states he's been experiencing tingling and numbness in the feet, perhaps due to diabetic neuropathy. The audiologic results, otoscopic inspection within normal limits, and I'm probably going to butcher these things, so I might let you all help me through these things as we discuss the case. I'm learning from you all today. Pure tone thresholds, otoacoustic emissions absent, fair word recognition scores, 72% the right ear, 76% the left ear at normal conversation speech levels. Speech and noise test results indicate moderate speech and noise ratio loss. And what we have asked all of the teams to do was, the first question is focusing on the audiology side of things, what the audiologic recommendations would be, how the patient and his spouse would be counseled, what might their responses be, explaining the findings and including results of a needs assessment, establishing and listing functional goals and desired outcomes. So this is very discipline specific, the first question. So we have a willing team number 4, who is going to share, yay for team number 4, who's willing to share their results. And then what I'm going to do after that is ask if any of the remaining tables have comments to add, if you agree, if you disagree. So I will turn it over to team 4. You good?
All right. Oh, you can hear me. Okay. Is this working too? Everything's working? Okay. I'm Anna. I'm from JMU/Team 4. And so the first thing we kind of wanted to do was list the different problems as patient reported to us. So basically the case history that was just listed, I'm not going to say everything again, but the first thing we wanted to do before anything else is we wanted to establish with the patient if he was seeing other professionals for these general health conditions. So the diabetes, the unsteady gait, the neuropathies, his weight, his diabetes in general. So we want to make sure that he is, first of all, seeing a professional in these categories for these different issues. And when we find out if he is or if he's not, either getting the contact information of these professionals or making sure he's referred to someone for these issues. So the next thing we want to do is we want to kind of do our part. So we've done all the testing, and so we need to, the first thing we want to do is informational counseling. So we need to explain those audiologic results. We want to make sure they're thoroughly discussed, and for his hearing loss, we want to use tools such as what we call the speech banana, the familiar sounds audiogram, so we can let the patient know what they're missing, what they can hear, what they're having a hard time hearing, kind of how it's affecting their communication in general. Now we know from his case history that he's having a really hard time at work, one, but also with his family and friends, with his relationships. They're becoming very strained. He's having a lot of frustration. And so we want to use tools for that patient, but also for that spouse who came with him, for optimizing communication environments, so that those strategies with the teaching facial cues, teaching optimized communication, so face-to-face talking, not talking from different rooms, not talking while the TV's on, or when music is playing. And the really important thing about that is to make sure we provide them with printed instruction So materials to take home with them so that the spouse can remember, okay, how am I supposed to talk to my husband? How am I supposed to work on our communication? They can look at these printed instructions, but also to share with other family members. And it's also kind of important to teach patient ability to stand up for himself in work environments. So if he is having a hard time at work, he needs to explain that, I'm sorry, I do have a hearing loss, and if you want to talk to me, you need to make sure you're facing me, you're not turning away from me, trying to tell me to do something, because I may miss some of the things I need to do for work. So the next thing we want to do is talk about the patient's hearing aid candidacy, and he is a candidate for hearing aids based on his audiologic results. So he says that he is motivated by his job and family, but he may still have doubts. So we need to talk to the patient about his willingness to get hearing aids, because like he said, he's afraid he's going to lose his job, but also the price behind hearing aids, and also the general concern of being someone with hearing aids. He may still have doubts and may not be ready to jump on it yet. So we need to talk to him, counsel him, let him know what the hearing aids can help him with. Considering he decides that he does want a pair of hearing aids, we need to assess his needs. So we want to assess his needs in a qualitative and a quantitative way. So we already have a lot of qualitative from the case history, and we can continue that by talking to him about his different needs, but also quantitative. We use this in our clinic. We use an assessment questionnaire. So it's basically like a questionnaire that lists like what if they go to restaurants a lot, if they do a lot of quiet activities, if they have a very high stress communication work environment, and it lets us know what level of technology they need in hearing aids and what different additions they need. If they need for example, if they do a lot of telecommunications, and if they need a hearing aid that makes sure that always connects automatically to their phone and work environments and everything. So we need to make sure we do assessing all of his needs, and then once we choose a hearing aid based on those needs and we fit him, before we fit him, we want to go ahead and do a COSI. If y'all all do COSIs, we want to basically, or any way to list the goals that the patient has. So the different goals he wants in his hearing aids and his amplification. So improving the work environment, improving those relationships with family and friends, and other specific situations where he needs help with his amplification. Establish those so that once we fit him, we can come back to those in future appointments and address them. We want to fit him with a hearing aid based on his needs and goals. Once we're fit, we're going to ask him to keep a journal about the pros and cons of his hearing aids, what helps, what didn't help, what actually is worse, what sounds funny. And we're also going to have him fill out an AFAB. So an AFAB so that he can let us know the different, just in case, so a journal is very open-ended. He may not think exactly of what to write in a journal. So an AFAB is going to help him kind of itemize that information and think of all the things that he needs to address. And so that basically lets us know in what situations things sound better for him with his hearing aids and what things sound worse. And so that's what we have.
What teams have anything to add? Did they miss anything? I'm going to rely on you all because it sounded very thorough to me, but that's not my background.
Sorry about that.
At the risk of doing more tests. Is this on? On, okay. I think because of the proprioception issues, it'll be good to do a risk of fall assessment. That's what we talked about, that, or vestibular assessment probably. That's one. And the second thing we talked here is about an issue, who owns the problem? Here, in this case, looked like, at least the hearing problem, the wife owned the problem most of the case. The patient was trying to not or avoid revealing that he had hearing loss. So maybe HHIE, hearing handicap inventory, for the patient and the significant other, so that you could compare what is the difference, the gap between the patient's perception and the caregiver's or the wife's perception. So those are two different things we talked about for question one. Did I capture everything?
The only other thing that we talked about was because he has military history, is that necessarily talking to him about VA assessment, or if he is a candidate to receive assistance from the VA or hearing aids from the VA, and other opportunities the VA might offer him that we might not be able to offer him as audiologists. That might be a good option for him, especially if cost is an issue.
Other comments on the first question about the plan? Yes.
Just sort of adding to what Dr. Rout was saying about owning the hearing loss, we also said you could suggest that he and his wife go to a support group for hearing loss and for, coming to terms with that.
Okay.
We also talked about how assistive devices might be helpful to him, maybe like some kind of streamer or a TV link to help him at work and at home.
Okay, first, there were two things. One is to focus on the audiologist being a source of hope. For us, as we were saying, he's afraid he's going to lose the job. And so coming to us, we want to, at a certain point, try to reinforce that there is hopefully things that we can do for that person, to give them a chance to know different options, but we will help him in a way where he can address the issues that are affecting him. So we start off like with empathy and then objective and then go back to empathy. So at the end, we've established trust and we want to then reinforce that there are things that we can do. Second thing, going back after our role there, is that the sleep and anxiety are issues that can add on to the hearing issues. And so we have to know, by talking to other professionals, that's not just hearing, but also the ability to process, because if he's tired or if he's not getting rest, his arousal level will be low and he will have more difficulty. So then we need to take that information. Are there times of the day where he may be more alert? Can he arrange meetings where he may be more alert, because there are times where he may be more fatigued? So can we possibly work on that schedule, knowing that information? So there are other factors that are affecting besides just hearing.
One of the pieces I would say related to that, we used to have a program kind of similar to this at Jefferson, where we broke the students up into groups and they were given paper cases like you were all given today. And one of the things that the students really enjoyed learning about each other, and this is where I'm learning from you all today, you all do these tests. I never heard of these tests before, or what they look at. And you mentioned a couple of forms, and I asked Deb, I'm like, are they standardized audiology forms? And she said yes. You know, part of that, that's what I was wondering if I needed that. That's okay. You know, part of that learning about piece, you learn a lot about people. Like, what do you do? You know, what do you do? You know, these forms that what do they look like? What type of information do they gather? Some of the information might be similar to information that some of the other disciplines gather. So there might be some overlap, but there might be pieces that are different. But the students, one of the cases we had, it was a Parkinson patient. And, you know, the OT and the PT students had all kinds of different tests and things that they talked about relative to gait and functioning and walking that, you know, it's like, can you explain these to us? And it was wonderful. You know, so the things that you all do, you know, helping me to better understand when you were presenting about, you know, the technology and all the things that go into your decision-making process on what type of a hearing aid that patient requires. It's second nature to you, but wow, as I listened to it, that was really very interesting, very exciting, and truly makes me appreciate the things that you all do. When you share that with other people, it makes them really appreciate the things that you do. When they see all the steps and the thought process that you had to go through to get to that ending. You know, when we talk about, and we're going to jump into the next question about the other disciplines, the same type of thing. Like if you knew what all was involved in an OT assessment or a PT assessment, you know, that one piece of the competencies when I talked about values and ethics and roles and responsibilities and really understanding what everybody brings to the table, you know, this is it, you know. you have your role down. You got to teach other people your role and make people, appreciate the role that you have. So it was really good stuff. I don't think, I'm looking to you all. Was anything missed? All right. So thank you, Team 4. And we'll move to Team 1, who's going to present on the question that asked, form an interprofessional team. And I will have you focus just on the piece of listing and then providing your rationale, because the last question is how the team members would work together.
So we talked about some different pieces of this team. Obviously, number one, you want your patient and the family to be first on this list. Also, the audiologist is going to be very important. We had talked about maybe doing some more testing on the vestibular side, potentially. If you're looking at balance problems, it could be related to the diabetes, but we're not sure. So that might be something that we could look into more. Also, we want to be in contact with the physician. This client has a lot of medical issues, so we want to be sure that we are contacting the physician, and maybe there are some other specialists that we wouldn't know about if he's getting any help with his sleep disorders. Maybe there's some other people that are involved, so talking to the physician about that. Also a cardiologist, he's got some issues with AFib, so just getting all the information that we can about this client so that we can get a full picture. A psychologist to help with some of the anxiety and the sleep issues. He's also just having a lot of tension with his relationships right now. He's having a lot of stress from work, with his family, so addressing that issue. And we had talked about the potential of a social worker. There's just a lot of different pieces here, and I might not know how to put all of them together. So if there's another professional who knows how to coordinate something like that better than any of these individuals, that might be a good thing to look into. Maybe PT, if the issues with his balance continues, an assessment for that would be helpful. And then later on, we're not sure how comfortable this patient would be talking to his workplace, talking to his boss, but he is going to need accommodations in the future. And so including them in this discussion is going to be helpful as well.
Do any of the groups have anybody to add? Were your teams all the same, or did you have different teams? I really can't read any of your boards from the front here, so you'll have to. Yes? They're pointing at you.
We also talked about an SLP potentially being on the team for AR support and things like that. We also talked about having a dietitian if we have problems with diabetes and high blood pressure and things like that. Can diet help make accommodations that maybe medication doesn't need to? So we might try to look to that first. Those are the two I can think of off the top. Speech language pathologist.
I don't want to offend you, but a Pharm D is the one who's going to be best to coordinate the medicines here.
Yes.
Okay, so I know in talking to physicians that the Pharm D is actually the one who will know the interaction. There's so many medications here, and they can interact in a negative way, and doctors don't. They know maybe certain medication, but they don't know the interaction as well as the Pharm D. So I just thought of that as, and then looking at you made me think of that too.
Yeah, my thought there was this patient has tinnitus. Tinnitus is sometimes drug-induced. It says he's on aspirin. I don't know how much aspirin he takes, but from my pharmacy hat, those are some of the things that I was thinking. And do you have a pharmacist, gets back to that question, physically on your team? You might not. But do you have a friendly neighborhood pharmacist that you might really like and trust that you could call and bounce things off of? So they're still kind of part of the team, and you're still utilizing their expertise. Depending on where you practice, you might have someone. If you're within a hospital setting who might have a really good drug information center, this would be the one where you pick up the phone and you talk to that drug information pharmacist and say, here's my patient, here's what's going on, and here's his meds. Anything jump out at you? So utilizing that. Other people on the team folks that you think were missed, or are we pretty complete here? PT, cardiologist, the psychologist, the dietitian was mentioned. I had that on my list as well. But part of this does get back to the patient-centered side of things. And what's he willing to do? what he's willing to do, and one of the teams talked about this up front, what he's willing to do and what the wife wants to do might be two very different things. So you need to kind of, walk that balance. But really, if you want the plan to work, it has to be something that he wants to do. Now, dietitian-wise, and this is where, if the wife's the one who does the cooking, you can involve the wife, and, she can be the driver there and do some of that, if that's the case. If he's the one that does the cooking, you might have some trouble. But anyone else on the team? Pretty thorough list? Yeah? Okay. Now for question, who volunteered for question, or was there something else? Here.
Did anybody mention podiatrist? I didn't think I heard that. Oh, you did? Okay. I didn't hear that. Yeah, his feet were numb, I think. Yeah. Just an ad.
The other part for that could be a neurologist, whether there was a neuro was involved or not. But as you can see, the team's pretty big. It can be really big. Now, who all's involved at any one time might be, might depend, but the potential for this team and who all could really contribute to the optimal outcomes of this patient are pretty broad. And who was it? It was group 9? Okay. Do you have stuff on your board or no? Yeah?
My name is Julie. I'm from Towson University. I'm a first year. Okay, so we just, basically all we really had to say for this was that we would want the team to share the reports. So we talked about the different ways we could share the reports. I know we could fax, we could mail them, but we also discussed the electronic medical records system, because that would be convenient, especially within like a medical setting at like a hospital, because we discussed how within professionals, if you email them, they'll just pop up in their mailbox instead of them forgetting about the reports. It's more convenient. And then I guess just get them in a timely manner and be available for your team. We don't really know what else to say for that. Patient-centered care. So as a wrap-up, we would just want to make sure that we're covering everything, following through with recommendations, making sure everything is covered. So that's all we really have.
All right. I'm gonna, if I can I put your team on the spot? Okay.
All right. Hi, everyone. I'm Jess. I'm from University of Maryland. We really wanted to make a visualization of what patient-centered care would look like for this patient, and really making sure that the patient and his family was at the center of the IPP team. And we basically just wanted to make sure that we know, of course, that all the different professionals are communicating back and forth with the patient and his family, but it's all about making sure that these are connected and making sure that we can have a discussion with every professional that's a part of the team. So really emphasizing this connection as we go around the circle and making sure that the circle can be complete. So that's what we focused on when discussing collaboration with the team.
Other thoughts and questions on this one?
We talked about having the need to get away from our traditional style of report writing. So a sloping 2K notch. So that really does not go well, or people don't understand. So basically, using a functional model of our diagnosis, saying that has a moderate to severe hearing loss that leads to difficulty in speech understanding. So that way, a report is easily understood by everybody. So we could send a whole page, but they will probably not use it. Students like it.
What do I need to know, right?
Ask how people would interact together. And we put stay in your scope of practice, because we've had instances where, we recommend one thing and a physician says, oh, you don't need to wear the hearing aid all the time, or you don't need to do that. And that's really our scope of practice as an audiologist. So just respecting each other on the team and staying in your practice.
That's a fantastic example. And that earlier when I talked about the speaking up type of thing, so you have someone who says you don't have to wear that all the time, but you're the one who really determines that the benefit they have from wearing it all the time versus just whenever they want. Part of that, and I will go back to the learning about, from, and with. The physician needs to know from you why it's important that that patient wear the hearing aid all the time. Maybe they don't know, and they just think that it's just an add-on type of thing that, oh, when you need it, you wear it. But if you can educate them as to the importance and why if they wear it all the time, then hopefully you're avoiding that physician doing that in the future with other patients. And it is identifying you and your role and your importance in the care of that patient. So we do find that. Yeah, I mean, physicians, sometimes relative to medications, that may happen. Oh, you can split that. No, you can't split that. That drug isn't a formulation where if you split that, it's no longer sustained release. You can't split that. So just as I'm sorry, yes, it's a pharmacy example, but teaching them, oh, no, we don't do that because, so use that teaching moment to teach your peers in other professions what it is you do and why it's important, and it shows them your value. It shows them your value. Other thoughts on this one? A couple hands here.
I think another important topic to mention is clear referral guidelines. If on the case history we have tinnitus, it just says non-debilitating tinnitus, and I'm imagining the primary care saying, oh, do you have ringing in your ears? Does it stop you from doing these daily activities? No, then it's not an issue. Whereas the audiologist might go in more in depth, might want that referral from the primary care physician where the tinnitus is severe enough that we can help them manage it, we can help them treat it. Or if we get a referral from someone that has hearing loss or has ringing in their ears, they come in and it's once a month for a couple of seconds, and the physician's still referring them to us and taking up valuable patient time and space.
In pharmacy, very excited about that, especially in the community setting, because for pharmacists who work in the community setting, we've been so disjointed. You get the medication list that comes in and you get whatever information you can get from the patient, but we train and think about yourselves. Are you able to, because we all want to, you want to be able to function and as whatever it is you're training to become at the top of your level. And you need certain information to practice at the top of your game, whatever that is. And I use pharmacy as an example. In the community pharmacist, a lot of the drugs, to know if they're working or not, we require lab results. In that community setting, we have never had access to lab results. You'd have to call a doctor if you wanted to. So that group of pharmacists, for the most part, has not been able to function at the top of their game. If we really move forward and we have this electronic medical record that all of the providers on the team would have access to, we would all be functioning at the top of our game. And think about the patient outcomes that could result from that. As opposed to waiting for 6 to 12 months to reach the goal of some type of treatment, we might be able to reach the goal of that treatment in 3 months if we had the access and could move treatment plans along.
I have a question. I'm going to look this way. Sorry. I just want to make sure. I have a question in that, in terms of talking about a team, but going into the fact that many people have not had this kind of training and they may be in private practice, different individuals. What do we do relative to example in trying to address this individual's needs, and yet you have many people who have not received, they don't know about what different individuals do, and to reach out, how do you, a curriculum, we're going proactive now, but reactively, what do we do for people out there already in private practice to implement this kind of IPP?
Deb and I talked about this a little bit. So the question, how do you reach the folks in practice? Part of it is the professional organizations. So you have, from an educational standpoint, the accreditation side of things, but I would ask, those of you who are involved in the professional organizations, what's your professional organization doing to move IPE forward, to talk about its role in practice and to make folks aware that this is how we're training today's students. The students who will be coming to you, this is how they're being trained and this is what's expected, to get the organizations on board for those already in practice. So there's that piece. I mentioned to Deb, we were talking a little bit earlier, I know many of you will probably remember this commercial. When I was a kid, the Prel commercial, he tells two people and she tells two people and they tell two people, and it's basically seeing this expanding over time. And it's the way I view IPE and collaborative practice. We're training our students. If we can get a core group of folks in practice doing this, and then the students who are entering practice are doing this, doing it right is a culture change. Those things never happen quickly. They take years and years, sometimes decades to happen. But as the students go out into practice, and again, I go back to when you guys are looking for jobs, what does the place look like? What's the culture look like? Who do they interact with? Who do they interface with? Or do they just interface with each other? Do you have the opportunity to reach out to others and work with others? It's something that takes a first step. And not everyone's going to do it, and not everyone's going to be on board. Some of the folks I was talking to this morning, like even at the university level, there's always going to be those who, we already do this. I don't need to hear about it. I don't need to learn about it. And I've gotten to the point after 10 years, I ignore those people. I just ignore those people. I would say I just ignore those people. There are the people who jump on board, and I worry about some of our faculty burning out who are doing this because they're putting such effort into it. And then there's the folks in the middle that I know they're going to move along. And that's the bulk in the middle. And that's where I say, okay, this is good. Even the students, those who, and those who love it, and those in the middle. Those who, that's maybe someday, maybe when they're out in practice or moving forward, they'll see the value. And if they don't, oh well. So that's where I think as providers, regardless of what kind of a provider you are, take control of your own. What can you do and what can you influence? A lot of this is empowerment of yourself, empowerment of your profession, teaching others about your profession, but being open and learning about others as well. How can they help you? What can you learn from them to help you do better? Does that sort of, it's a hard hard question to answer, but starting somewhere and knowing that it's just being very patient. Other thoughts on this one? Do we miss anything? Hand in the back.
All right, so our team was thinking about how do we make a team that the patient wants to see, because it sounds great to have 30 doctors on his team, but no one has time for 30 doctor appointments. So we were going to say, hopefully a lot of these doctors could all be in the same area, maybe in a VA since he was in the military, so that all of his stuff is right there. He's not having to run to this doctor, this doctor, this doctor. He doesn't have time for that. He's already worried about losing his job. His job's not going to be like, sure, take 20 days off a month and go see your doctors. So that was like, how do we realistically tell him, okay, go see 20 doctors? Yeah, like who's the best?
It's a really good point. That speaks to kind of coordinating care and what's in the best interest of the patient.
I think we're also at a very exciting time where we have research that's supporting this connection of hearing loss and wellness. And that when you look at this particular case, you can see that the hearing loss could be contributing to his stress and anxiety. And as you were indicating, that given the wealth of issues that he's having, that you need to look at this case as a whole and how each component is actually influencing his health and wellness, and that hearing loss is a contributing factor to that.
Take that health and wellness aspect road. That's very easy for all of us to work together as a team when we focus on health and wellness and not just trying to always fix things, which is what we always try to do. But if we really take that health and wellness and preventive standpoint, it's that longitudinal program that I focused on. So those are the students right when they walk in the door. They don't know a whole lot. The pharmacy students in their first year, they don't know much about drugs at all. The medical students just walked in the door in July, and we're putting them together with the pharmacy students, come August. They're all fresh. They, what they know. But you start talking about things like health and wellness, A, they can think about themselves. B, focusing on that with their mentor. They're able to do that. And then as providers, we talk about cost of care. Boy, we all know if we put more energy into health and wellness and prevention, the cost overall of healthcare would not be where it is today. We spent too much on the other side of the equation. So, any other comments? I think we're almost perfectly at 12:15, which I think I stand between you and lunch now or something like that. I did want to make one comment, though, an error on my part, just to bring, it was brought to my attention, so whether these were new or whether I looked at the wrong spot, you must have new accreditation guidelines that go into place this year or next year, right now. And they do include the terminology of interprofessional education. So I think the description that I had must have been the last set that you have. So you have new ones going into place. So that's quite exciting for me. So the terminology is there, not just the description, but the terminology. So I do stand corrected on that and thank, where is he who pointed it out to me? Did he leave? I forget. He must have departed.
Oh, Neil.
Neil?
Yeah, Neil must have
Neil
stepped
departed?
out.
Okay,
And I think they go into effect in June. So they're
okay.
probably not on our
So
website.
coming forward.
Yeah.
But I guess anybody who is up for accreditation after that, you are. And they'll be looking, which is, but I don't know. I know with our accreditation guidelines, they know this is something that's a process. You can't be doing it all at once. They want to see what your plan is. I would imagine your accreditation body is, what's your plan and how are you going to roll that plan out? I hope they would take that approach because it's not an easy thing to roll out. This is not an easy thing to roll out, but well worth it. So, any other questions or comments? All right, I think.
Let's give Elena a great round of applause. Thank you so much for coming, educating us more about IPE, IPP, and spending a lot of time with us.